basically my talk is about endoscopic facet sparing transforaminal interbody fusion. Now, basically it has been a quest. The quest is what? Okay, let us try and find, just 1 second, sir. This thing is troubling me, yes. Yeah, the quest is to find a way to achieve a true facet sparing approach, which is both effective and safe with minimal morbidity and is done under local anesthesia. So that got me thinking, and I decided, why not do a little modifications. We normally talk of P-lift, T-lift, but these things basically are misnomers because T-lift does not specify that you are actually destroying the facet before you do a fusion. And what happens when something goes wrong, when there is an implant failure or there is a subsidence of the cage? Then that side of the facet collapses completely, and that leads to secondary iatrogenic stenosis again. So if we can preserve the facets, then we are preserving the posterior interlaminar structures, everything, and therefore the question of secondary collapse, failure of implant does not occur because the load bearing on the implant also becomes much less. So let me play this video for you guys.
Good morning, welcome to Golden Park Operation Theatre, Endospine Suite. Today we are doing a case of transforaminal endoscopic spine fixation. We'll be introducing the cage through the foramen without violating the facet, and we'll be doing minimally invasive posterior screw fixation with reduction of a patient of degenerative listhesis, as you see over here. The L5 is moved ahead on the S1. There is collapse of disc height, and we can see that in extension there is partial reduction of this, but in a flexion view you can see that it's a grade 1 to grade 2 listhesis. Now, if you see here in the MRI, you can see there's a huge broad-based disc bulge because of the listhesis. It's a very tight foramen. Bilaterally, patient is having severe claudication. There are wet facets that are observed, thickening of ligament flavum, but basically the sac size is quite capacious. So I feel that by getting a good discal height transforaminally and minimally invasive fixation and debulking this posterior discal surface through an inside-out approach, we will be able to restore this spine to its normalcy. This surgery is basically being done under local anesthesia, where the entire cage will be inserted under local anesthesia to the patient. And subsequently, after patient is given a sensory epidural, we will be putting in with the local aided 4 minimally invasive screws. The top 2 screws will be reduction screws, and we should be able to fix up her spine with the cage loaded with bone graft from the iliac crest, and hopefully she should be on her way to recovery. So thank you very much. Let's hope we get a good result today.
Start.
Yeah, what we are doing now is we are curating the end plate. Okay. Make sure that the graft that we put in through the cage has a good chance of union. And can you please bring the C-arm in front, Mr. John? And now we'll be taking a live shoot. And Shirley is going to focus on the screen. Go in front of the screen, please, Shirley. Yes. Give me a live shoot, please. Continuous. Yes, thank you. And as you can see, continuously shoot. Here now, John, please. As you can see, we are now curating and creating entire space inside. 1 minute, please hold steady now. No, don't shoot now. John, 1 minute. Shoot, please, John. Yes, now you can see that the curate is bent. And I'm trying to curate towards the upper end plate. Okay, wait, please, John. Shoot, John. Only single shoot. Single shoot. Single shoot. Shoot John live, shoot Kar. Yeah. Now you can see the gradual movement of the curate towards the upper end plate. We're creating the center of the disc. Okay, thank you so much. Stop shoot. Completion of end plate preparation. This is the superior end plate which has been stripped and prepared. Now I'm rotating the tube to expose the end plate preparation on the S1 vertebrae. So both the surfaces are now prepared and are ready to receive the cage. There are a few loose fragments which are being pulled out, flushed out, and we are ready to place our cage loaded graft in it. Good. Short. Short. Ask her to move her legs, please. Focus on her face.
हे बघा पाय पाय उचला पायाची बोटं हलवा वर खाली करा
Yeah, ask her to move her legs. Wonderful. Is she having any pain?
दुखतंय का तुम्हाला काही हा तोंडाने बोला
Shoot John.
दुखतं का नाही ना
Shoot John.
ठेवा डोकं खाली ठेवा हा एका बाजूला करा
Shoot John.
दुखलं तर सांगा
Shoot John. Okay. Is she having any pain? Ask her, please.
दुखलं तर सांगा आई दुखतंय का काही कमरेमध्ये किंवा पायामध्ये
The cage properly engaged now. A thorough decompression being carried out from the opposite side. One can see the cage that has been inserted in the foramen. One can see the entire annulus which has been de-roofed and decompressed. There is no material, annular material or nuclear material posterior to the cage now that can be retained and be a cause of pain. So biportal endoscopy with insertion of cage through one of the foramens.
Now coming back to our experience has been with degenerative retrolisthesis, lysoslisthesis, and with severe canal stenosis. We have been working with these three parameters. And as you can see in this patient with retrolisthesis, we have placed the cage. And this was again at L5S1, we have come suprailiac, put in the 4 screws and locked up the spine beautifully. This is another case. You can see the patient's force marks on the back from where we have put in the 4 screws. And you can see also the one small cut on the side, which shows that we have put in the cage through the foramen. Here, this is a case of a 4-5 lysoslisthesis, which was corrected.
Yes. And the record this one. The right should later on.
This is again showing you how we use the curate within the disc space to empty out the disc space completely, work subannularly, remove all the fragments, and then go ahead with the fusion process, which I've shown to you. Trans-Foraminal endoscopic cage with minimally invasive screw fixation is a distinct possibility, preserving the facets, not destroying the facets, not creating iatrogenic instability, staying away from the neural elements completely. As you saw, we hardly saw any neural element at all in all the work that we have done. So this is the 10th day post-op of the patient. She's a little apprehensive and she's walking beautifully.
This is Kalpana. She has undergone a facet sparing trans-foraminal fusion with a cage and 4 minimally invasive screws. She has got a biportal endoscopic discectomy at the same level to remove all distal material from behind the cage.
cage, which is possible in a oblique positioning of the cage. The other issue that she had was a disc at a higher level, for which again she had to undergo transforaminal discectomy. Today is, I think, a 10th day follow-up, and she's walking comfortably. We are very happy to receive her today. Namaskar, sir. Thank you. So thank you from her to all the participants and delegates over here. I'll just wind up quickly. Advantages: basically you preserve both the facets. Cage insertion is under local anesthesia, no neuromonitoring needed. Second stage, we use epidural anesthesia for the MIS screws and rods. Patient is doing his or her own neuromodulation. There is a minimal blood loss, less than 50 cc's. There is a visualized end plate preparation. Graft can be deposited from the iliac crest in front of the cage, inside the cage, so that you can really pack up the cavity. There is a zero incidental durotomy or root tear. It is ideal for elderly patients with multiple comorbidities. And disadvantage, obviously, you cannot resolve a central canal stenosis. That would require an additional procedure. Expensive infrastructure and need for endoscopic training, which is common for everybody. But I think this is very much a viability, very much a very safe way of doing fusion. And I would like to thank you all on behalf of Endoscopic Spine Foundation India and my university, that is MGM University of Health Sciences, Navi Mumbai, where I'm a professor with the Endoscopic Spine Unit. I thank you all very much.